Good afternoon, everyone. Hello, this is Teddy Prasetyono coming back for you, and you are all welcome to join our session for today. For those who are in Europe or the western part from Asia, maybe you're in the morning, but then most of you are in the afternoon. And for those who are really interested from the American continent, you're maybe very early in the morning or still very dark on your side. But you are all welcome, and I thank you very much for joining these great sessions, which I believe you understand why this is great. So, this is the 6th ICTEC online updates in hand surgery. As you know, and many of you are aware that we have series in microsurgery, but we have also series in hand surgery. Although there are some overlapping in between hand and micro, you know, the work of hand surgery never been separated from microsurgery. So this time we will be together with Professor Isao Koshima. I believe, you know, he does not need any, what you call like introduction, because everybody knows him. So as the beginning of the sessions, I just would like to remind all of you that we do really appreciate if you do not take pictures of the slides and even make video. Myself, Teddy Prasetyono, and also Professor Koshima do not have any financial interest with these sessions. Professor Koshima has its own disclosure with conflict of interest. Maybe it's only because of the precious book that he has ever published. The session is organized by the Indonesian Clinical Training and Education Center, which is a simulation center and clinical skills lab of the Cipto Mangunkusumo Hospital in Jakarta, the top referral hospital of Indonesia, as well as the Faculty of Medicine Universitas Indonesia, also in Jakarta and Depok and western of Java province. All right, so the session is also organized together with the Indonesian Society of Hand and Microsurgery, and also got endorsement from the Indonesian Associations of Plastic, Reconstructive and Aesthetic Surgeons. I believe you know Professor Koshima. He is very famous, and everybody understands that he is called or recognized as the father of Supermicrosurgery. Currently, he is in the position as president-elect of World Society of Reconstructive Microsurgery. He's also the founder of international course for Supermicrosurgery. And if you recall many techniques in microsurgery, he's the one who created many important flaps that becomes armamentarium for so many reconstructive works. That would include the main area in the supermicrosurgery he has been developing in the lymphatic surgery. He also the one who introduced vascularized nerve flap, and also an example for voice reconstructions using appendix free flap. You know, these all are only some of his tremendous, massive work in microsurgery. All right, so good. Oh, I still remember that this one is only one photo among many photos that I have with him in international meeting. I believe this one was in Korea back 3 or 4 years ago. All right, so ladies and gentlemen, you are also aware that this session is a session where we are all going to visit the Komodo Island in Nusa Tenggara, the east part of Indonesia. So the eastern Nusa Tenggara province, where these islands, one of the group of islands is Komodo Island. If you consider to visit that island, you need to stop by at Labuan Bajo. You may reach the Labuan Bajo from Jakarta or from Bali. It depends on your preference. All right, so be ready with your passport. Professor Koshima has already been online. On board. So let's go flying, and we will be landing soon in Labuan Bajo.
A budding tourist destination in a panoramic fishing town. of Labuan Bajo. A perfect retreat for peace and tranquility. And for those who seek adventure. Amazing dive sites. Magnificent underwater life in glassy seas. Exploring and discovering is never ending. Stunning landscape. Delight in the legendary Pink Beach. Uncovering Earth. See the nocturnal. And feast on the splendid scenery. Isolated to conserve. Land of the Dragons. Sanctuary for the endemic. Natural habitat of the giant lizards. Beautiful beasts. Magnificent journey into the wild. Komodo Island. Wonderful Indonesia.
Great. So don't forget to come into the learning sessions, and only walking around in the Komodo Island would not be good without learning. All right, so let's greet Professor Koshima. Professor Koshima, how are you? Sorry, you're
Okay.
still muted.
Yeah.
Let me unmute you. Yes, you
Okay.
are in now. How are you?
Oh, hi. Good afternoon, everybody, ladies and gentlemen. Thank you for coming this webinar. Today, I'll talk on the supermicro and nanomicro for hand reconstructions. For these maybe 20 or 30 years, I'm doing the proposing many techniques. So today, I'll summarize and talk this 30 years history. Probably everybody forget the previous former surgeries. So please recall and try. Everything is completely new for a young generation. But this is very challenging surgery, so try. If you succeed one of these techniques, you are a hero or heroine all over the world hand surgery. So please enjoy a series of the supermicro technique.
Thank you. That's a very encouraging statement.
Okay.
All right, so
you prepare my talk?
Yeah, okay. I'll share it. Yeah, from my side.
You are now arranging?
If only my connection is not perfect, hopefully you could take over for some seconds.
Mm-hmm. Today I'll talk on the new era from supermicro to nanomicrosurgery for hand reconstructions. We propose a supermicrosurgical concept. This means a microvascular dissection for smaller vessels and also anastomosis for those smaller vessels less than 1.02 millimeter. Also, single fascial nerve anastomosis is also included this concept. Hello, everybody. Today, I'll talk on the new era from supermicro to nanomicrosurgery. Nowadays, I'm going to the nanomicrosurgical field. This means a new revolution of microsurgery is now started. This is my COI, newest publication on super microsurgical lymphovenous anastomosis. So lymphatic surgery could be available with Amazon. This is my own classification of powder grafts. Long vascular pellicle convenient brick graft and true perforator. Also, short T pellicle perforator is already published. Supermicrosurgery includes the perforator to perforator graft using true perforator graft and adposer graft, fingertip replantation, toe tip transfers, and the vascular nail flap, and lymphovenous bypass, and vascular nerve flaps. And also tibia, periosteal flap are also very useful. Now, we are new era of super and also nanomicrosurgery, which includes nerve flap, nerve bypass, lympho bypass, less than 0.2 millimeter, and capillary perforator flap, and invisible surgery, such as cellular surgery and the vascular cellular transfer would be available from now. For this case was long-standing sensory loss of the thumb after trauma. So I explored the neuroma. So there was a 2 centimeter nerve gap. So I elevated the bilateral fascicular transfer, fascicular flap transfer, and anastomosed the with 15 micron very small needle. This need a supermicro technique. So this is the kind of nerve flap. So post-operative result was very nice. 10 weeks after surgery, Tinel signed the fingertip, and a very nice sensory recovery occurred after 4 months after surgery. This case was also a fingertip amputation, distal from the genital arch. For this case, after arterial anastomosis distal to the genital arch, we took excess arterial as an arterial graft between bilateral venous drainage. So this is the post-operative result 2 months later, complete survival occurred. This case is a lady who lost distal thumb. She had tenderness when she's pinching. So distal tip of the distal phalanx was missing. So distal toe tip was elevated as a free toe tip transfer. So this includes the distal phalanx. And this is post-operative reason, only the distal tip of the thumb, including the distal bone completely survived, so completely normal tip of this thing. So this is the X-ray show the survival of the distal tip of the phalanx. This is 5 months after. Also, toe tip transfer with a very tiny digital artery dissection. And this was done around 30 years ago. That's why the proximal dissection of the pedicle vessel was tried. But nowadays, we need not dissect proximal pedicle, only distal, short pedicle flap is enough with nanomicro, supermicro technique. Pedicle vessel become shorter and shorter. So probably with a jigsaw block, both toe and finger, this surgery will be completed within 7. So with this trim the second toe tip transfers, this young woman, young girl, who lost little fingertip was repaired with a minimum invasive technique. So now she got a completely normal nail. So toenail, corneal deformity could be easily repaired with this technique. This is a kind of aesthetic finger or hand reconstruction. This case shows the bilateral second toe distal phalangeal transfer with a pair neurovascular bundles. This was also 20 years ago. I operated this case, so that's why the proximal dissection done. But nowadays, we need not to do the proximal dissection. Only short dissection is enough. This is a 9-year-old girl who lost distal phalanx of the middle and ring fingers. And this distal phalangeal transfer was done for this young girl, very young girl. But 4 years later, this was completely acceptable aesthetic result. This is a kind of aesthetic hand reconstruction, hand repair. This case was done the multiple vascular anastomosis, so double arterial, also double venous anastomosis was done. So this kind of multiple vascular anastomosis is very, very important, even for the pre-flap transfers. So we need not do the exploration with this multiple vascular technique. This case is iatrogenic disaster. Also pedicle hand surgeon repair with boral advancement technique of the fingertip defect. But unfortunately, total toenail were necrotized with transection of the feeding vessel of the nail. So he asked me to repair this nail. So second toenail was obtained with short, only 1 or 2 centimeters, 2 tenths vein, and also a digital nerve and artery. This is post-operative result. 10 months later, semi-science showed 4.7, not so good, but nail was completely surviving, growing. He was satisfied. This case is a iatrogenic ring finger necrosis after the boral advancement flap. So complete necrosis of one nail occurs. So another hand surgeon asked me to repair this nail loss with short lengths, only 1 centimeter. So the short length of the digital artery and also cutaneous vein and digital nerve. Other digital broke. So I took the second toenail and transfer. Also, medial plantar perforator is a very, very small, but with this perforator flap, this kind of pulp loss young man who had tenderness of the finger. So medial plantar true perforator flap was pain and cover transferred to the pulp. And the recipient vessel was digital artery perforator. So perforator to perforator flap, medial plantar, perforator to perforator. The vein was a cutaneous vein. Transferred. So 4 weeks after surgery, defects still exist, but finally, this defect was closed spontaneously. Nowadays, digital artery perforator flap is now become popular for fingertip coverage. So this is less invasive. This is a kind of capillary perforator flap. Also, next topic is vascularized nerve flap. So all peripheral nerve has a rich vascular system, extrinsic and also intrinsic vascular system. This is the right sciatic nerve, which has a very rich vascular system. In 1985, I proposed experimental work on the nerve using right sciatic nerve. So contralateral free sciatic nerve pedicle with a femoral vessel was transferred to the ipsilateral nerve gap. And periodically, histometric analysis of nerve regeneration was observed. This was the experimental model of right sciatic nerve. Our femoral nerve was anastomosed. This was 8 weeks after the surgery. Vascular group, VNG, showed the very thick nerve trunk, grafted nerve, but control non-vascular nerve shows the absorption. Also, histological examination showed the nerve flap showed the very rich myelinated axons appear within nerve flap, but control group showed no regenerated myelinated axon. This is a histometric analysis of the proximal A to the distal ankle E level. So at the distal E ankle level, solid line show the number of the myelinated axon, and the dotted line show the control non-vascular nerve group. They're not so good axonal sprouting, but nerve flap group show the very rapid nerve sprouting. This was published in 1985. So nerve flap has a very nice nerve regeneration, and clinical application is nerve transfer, nerve crossing. Also iron nerve flaps and free vascular nerve flap, and also some other nerve flap technique proposed. Based on this experimental model, we got the result of nerve flap show the very rapid re-innervation for the end organs. So clinically, nerve flap include the fascial transfer and the fascial turnover and island and free nerve flaps. So this case, high school students who had a lower plexus injury, long-standing injury after traffic accident. In the first stage surgery, 25 centimeter deep peroneal nerve flap transferred to sprout the motor axon of the intercostal nerve. 2 years after surgery, a distal tip of this nerve flap showed the myelinated axons. Very nice. So in secondary surgery, free gracilis muscle transfer for flexor function of the forearm. And this is the gracilis muscle transfer for flexor functional reconstructions. 2 years after surgery, he can flex the fingers against the dynamic sprint. This shows the axonal cytoskeleton within the myelin sheath. So there is cytoskeleton, myotubes, microfilament, and also mitochondria. These components, these cytoskeletons are moving from proximal to distal. This is longitudinal section of the axons. N shows neurofilament, T shows microtubules. These components are moving from proximal to distal. This is the axonal transport. This is very important for clinical cases. For example, this case had a very severe pain after endoscopic carpal release. So instrument injured the median nerve. So she had 4 years, very severe pain, comparing very severe pain. Always protect with a glove. So I explored the median nerve. So there is a big neuroma. So I put the nerve flap bypass. We use the ALT neurocutaneous flap, including the lateral femoral cutaneous nerve. And this neurocutaneous flap was transferred to the carpal release area. And just after the surgery, she can use the this hand without the pain. And later, this flap was replaced by the medial plantar full thickness skin graft. So pain was completely disappeared. As a free combined tissue transfer, chimera type and ology type combined tissue transfer existed. The chimera type has single source vessel with several components. Ology has a complicated combination, additional free flap transfers. This young man lost some distal area, including the IP joint. So wrap around the flap from the with PIP joint, including the extensor and the flexor tendons, was combined tissue transfer, chimera type tissue transfer. So this is the chimera type combined tissue transfers. And this is post-operative result. IP joints are moving and appearance also near. This X-ray shows the movement of IP joint. Well, this case also severe heat pressure injury of the forearm. So radial bone completely necrotized. Also extensor tendons are completely necrotized. So radial vessel also completely necrotized. So everything rejected. Only ulnar bone preserved. So for this, I took the peroneal osteotendinous neurocutaneous flap, so saphenous nerve included to restore the superficial radial nerve or everything. So peroneal, vascular peroneal tendons, extensor tendon repair, and fibula replace the radius, and the peroneal vessel interposed into the transected radial vessel, radial artery and commutant vein, and the peroneal tendon for the extensor tendon. So one stage reconstruction of this. This is not the dear orochi concept, but near similar to the orochi concept because of the bilateral vascular flow through vascular anastomosis. This is the supercharged arterial anastomosis. So this is the kind of also nerve repair was done. And this is the 2 years after surgery. PA joint is not so good movement, but PIP is a very nice movement, show the very nice movement. With this orochi concept, we can make this kind of very severe floating thumb 10-year-old girl. First, deposition of the this floating thumb with iron thumb transfer, and also simultaneous tap flap, including a small LD muscle, innervated LD muscle with long motor nerve for a dynamic adductor muscle reconstruction. Also, combination free scapular flap because the pedicle vessel is very short. So once this scapular flap transfer as the free flap, so additional vascular anastomosis is necessary. But this is not a orochi. This is not a skip. Orochi concept is necessary, and the combination in the hand. So scapular flap, scapular bone pedicle was anastomosis to the branch of the thoracodorsal system, distal end of the thoracodorsal vessel, and also motor branch of the motor nerve of the LD muscle was anastomosis to the single fascicle of the ulnar nerve. And
So excuse me for the disconnections, but I would like to share it back to you.
Vascular anastomosis to the transected ulnar vessel. So flows through vascular anastomosis, nerve anastomosis, supercharged anastomosis of the scapular vessel to the distal end of the thoracodorsal system. So this is completely triple component. Supercharged vascular anastomosis. This is the orochi concept, one stage orochi. So post-operatively, this muscle move very well. So dynamic reconstruction of the adductor function of the thumb, but the color of the flap is not so good. So patient asked me to change the color, so I changed with a medial plantar full thickness skin graft, replacing this skin flap. This is another case. A young woman, 28-year-old woman had advanced rhabdomyosarcoma originally from the biceps muscle, so full thickness defect, including the median nerve, 15 centimeter, and also brachial artery loss. Also, distal portion of the distal half of the biceps muscle, also skin defect, big defect. Neuro, arterial, also muscular was defect. The LT flows through flap with saphenous vein for brachial arterial loss, and femoral nerve, 15 centimeter, was also obtained with this true powerless flap. This true powerless flap was anastomosis to the powerless of the descending branch, because powerless of this flap was cannot dissect to the proximal descending branch, so that's why the powerless was once transected and anastomosis to the other powerless. Also, motor nerve was repaired 15 centimeter. This was a partial nerve flap, so brachial muscle was connected with the free fascia graft. Also, some fascial transfer, partial pedicle nerve flap, ulnar fascial transfer to the median, transected the median nerve, a motor branch of the forearm muscle, fascial transfer also established. And this is the 11 months after surgery, Chinero sign advanced to the palmar region very fast. And also 1 year and 2 months after surgery, Chinero sign advanced DRP level of the median nerve, and 5 years after surgery, no recurrence of sarcoma, and Siemens Weinstein showed the 25 millimeter. 2 PD was 25, not so good, but Siemens Weinstein 3.22. This is amazing, because this is the nerve flap result of the nerve flap, 15 centimeter for the elbow defect. Finally, Siemens Weinstein showed the 3.22, very nice sensory recovery. Also, flexor muscle function restored very nice. So he can grasp the some big object, and the elbow flexion also possible. So he can eat everything with this right hand. This lady had a very severe pain, even at night time. She cannot sleep because of the compression due to the radiation or the adenocarcinoma in the axial region. So already subclavian artery obstructed. So after releasing this contracture, one-stage reconstruction, including the LT, including the rectus femoris muscle for dynamic biceps reconstruction. Also, saphenous vein graft for collateral bypass of the brachial artery and descending branch of the femoral system for the interposed into the obstructed brachial artery, and rectus muscle reconstruct the biceps muscle. So motor nerve of this muscle was anastomosis to the motor branch of the intercostal nerve. Post-operative result was very nice. So all the vein graft and also descending branch of feeding vessel of the muscular cutaneous graft was completely patent. and pain was completely stopped, so she can sleep in a lying position. In summary, now we have a new concept on super and nanomicrosurgery, perforator to perforator flap, flow through flap, and chimera orochi combined flap, and also nerve flaps. This will open the new field for hand reconstruction.
All right. Thank you very much, Prof. Koshima. Wonderful. It's all amazing outcome. And what was very interesting, if people and myself notice, are so many works that you have published very long time ago, even 80 to 30 years back. And you have started very early where so many people have not been realizing the existence of this marvelous technique in the supermicrosurgery, and also coming up with the nanomicrosurgery. So ladies and gentlemen, just to give you a brief review, that the concept with the nanomicrosurgery is anything in the microsurgical work that is connecting the tubular structures that is less than 0.2 millimeters. The supermicrosurgery itself is below 1 millimeter. So that's why the term with nanomicrosurgery is introduced by Professor Koshima. All right. So, Prof. Koshima, do you want to have something to add after the narrated PowerPoint that I've presented?
Yeah, thank you. It's completely, yeah, you summarize everything. Yeah, well, I want to say. So I presented this case at the 90s and early 2000. But now I'm thinking these too early. That's why these concepts are not so popularized 20 years ago. But now, it's the best time. These new, not new, old concept for me, but these old concepts, and now it's the best time to young generation will use this concept. So everything, perforator flap, LT, DIP. I first started middle 80s, but those are popular 20 years later. So probably nerve flap also I started 30 years ago, but for these 20 or 30 years, no one followed me, but this, now it's the best time. So I want to encourage young generation. Now it's the time for you. These technique will be popular from now. So senior doctor is a little bit difficult. So young generation, it's the best time for you to start new surgery. Also, now we have a very strong weapon. This is a Supermicrotech. Also, Nanomicrotech will open the more elegant, more fantastic surgery. So we have a big field, a new era. Thank you.
Thank you. Thank you very much. You're very encouraging to the younger generations. And, you know, well, we could take the message that you are very rare of the senior group who are still very keen to work in this very small area. All right, ladies and gentlemen, before we coming up with discussions, I would like to invite you to join the key question sessions. This is going to be fantastic for you because you would get like some of the core message from Professor Koshima. If you do not really grab the idea, I believe you could get it with only some minutes more, just 3 minutes, I guess, would be more than enough for you to join the key question sessions. So you see the link in the chat box. You could follow the link and spend 2 or 3 minutes to respond to the questions. And once you respond to the questions with your answer, you would get the feedback whether you are correct or you're wrong still with the response or with your answers. Okay, let you start with the key question session. Just follow the link in the chat box, and then I will start the discussions afterward. Examples also good for you to see how the message of the concept with the supermicrosurgery and also the nanomicrosurgery, and we'll bring you later on also through fun sessions. We have prepared game session for you, which is good also for you to anchor the understanding about this concept that Professor Koshima has presented. Of course, it's not only about hand surgery. He also apply so many concepts, so many applications in other regions of the body. We'll bring you further into the discussions. Okay? Has everyone joined the key questions? So I will start the discussion while I'm also welcoming you all to use the raise hand button, or you could type your questions in the chat box. Well, Professor Koshima, there are plenty of examples of your marvelous work that you have presented. Let me just ask for clarifications in the term of fascicular nerve flap. Mm-hmm. So at the beginning of your slides, you introduced the turnover fascicular nerve. Would that be the fascicles that you detect through the microscope and only one single fascicle that you connect, or you may connect several fascicles of the nerve?
Yeah, I mean it's a single fascicle, not multiple. Okay. Everybody doing the multiple, but I think no need to use the multiple. Single fascicle enough, because if you sometimes we sacrifice the normal nerve. In that case, we need not sacrifice a multiple fascicle, only single fascicle. And also, this is the same concept as skin flap. So pellicle skin flap, if there is some defect, nerve defect, in that case, we should use a bilateral fascicular transfer, because the distal area of the fascicular turnover become ischemic. So that's why a long length of turnover flap is not so good. So bilateral, in that case, bilateral to make the short length. So these are tip of the fascicular flap. The vascularization is very nice. So always think the vascularity of the nerve flap, pellicular nerve flap, and also island nerve flap, and also free nerve flap, completely same concept as the skin flap. So always pay attention to the vascularity of the peripheral nerve. This is the very, very important point. That's why I changed the nerve graph to nerve flap. The words of nerve flap is very important too, to always think the vascularity within a tiny fascicle. Also now I'm doing the nerve fiber transfer. This is very important for trigeminal nerve. So bilateral trigeminal distal end could be anastomos.
Okay.
Very small nerve fiber also could be announced with nanomicro technique. So it works very well.
All right. So just to ask a bit of technical details, how many sutures that you put with one single fascicle?
It depends on the diameter of needle. I always use the 5 or 6 stitch, even if the 0.1 millimeter or 0.2 millimeters, as many as possible, using the very small stitch. So now we can use the 30 micron or 40 micron needle. And the length is usually 1.5 millimeter. So if you use this nanomicro needle, the number of stitch may be 4 or 5. Always. This is important. Even lymphatic anastomosis, 4 or 6 stitches are necessary using a very small needle. This is completely same as the vascular anastomosis. We should not use the big needle. If you use a big needle, the obstruction occurs. So small vessel, small needles are necessary.
All right. Okay. So if I bring you into jumping into the ALT neurocutaneous flap. So I understand with the similar case that you reconstruct the median neuroma.
Yeah.
You put also nerve transfer, and we understand that the median nerve is very big. So then the nerve from the flap that you put is only one single fascicle. Is that true?
Yeah, I always use the lateral femoral cutaneous nerve. This nerve is a diameter maybe 2 or 3 millimeters. So I took the maybe 15 or 20 centimeters of lateral femoral cutaneous nerve and cut segmentally and duplicate. So it become a big diameter. So duplication makes the big diameter. So I think this is the accumulation of axonal cytoskeleton and also microorganella. So very smooth passage is necessary. So neuroma is a very severe fibrosis. So axonal transport are completely blocked. That's why the proximal neuroma is the accumulation of the cytoskeleton, completely the same concept as vascular system. So very smooth stream of axonal flow is very important. That's why we should establish collateral bypass. So nerve bypass, concept of nerve bypass is very important for this kind of neuroma. But we must use the vascular nerve flap bypass using a nerve flap. Never use non-vascular nerve graft. Nerve graft makes the very severe fibrosis. So passage of axonal transport, protein flow. This is protein flow, completely same as the vascular blood flow. So where vascular bypass is very important. So this concept is also from now very important. We must change the previous concept. So we should not use nerve graft, non-vascular nerve graft. Always nerve gap should be repaired with a vascular nerve flap. This is essential for nerve surgeons. But this concept would be suppressed by the senior professor specialized neurosurgery. But young generation was against the previous wrong concept.
Right, thank you. So I just want to remind everyone, if you would like to dig more, Professor Koshima has started to do the study, and you could find his publications in 1982 in PRS with the experimental work going on with the publications in Japan Journal in 1983, and also in the Annals of Plastic Surgery in 1985.
Yeah.
So you could get the basic so that you understand how he gave you example on how he applies so that you could follow the surgical applications, not only by the concept, but also how to apply it.
Yeah, this is very important point. They always experimental work and also basic research is always important to develop the clinical application.
Great, thank you. I see that Professor Asman from Malaysia has put the text, but unfortunately I lost my chat box because of that several seconds of disconnections. If I could invite Professor Asman, would you like to say to directly ask your question to Professor Koshima? If not, then I would ask my assistant to read your text because I lost your text. What do you think, Professor Asman? Oh, good.
Good evening, Professor Koshima.
Hi.
I'm from Kota Baru. My boss, Professor Sukari, used to work with you. 2005, I think. So, okay. Now, I consider myself not so young, but not also so old. So, I realized that I first read about your paper in 2000, late 90s. At that time, I don't think it's actually human work can do like that, what you did. So, it's actually very difficult to actually this thing. But I'm actually starting doing that. But the most problem that I face during Supermicrosurgery is the technical part of it. that your pedicle especially, it used to be desiccated very fast when you raise the pedicle alone. You have any things that you do in your environment? How do you avoid that? Because you know very well when you are talking about perforated flaps, the flap itself, the pedicle itself is so vulnerable. You do anything in your, especially in your kind of an assistant, in your OT environment? How do you get the optimum environment to do a Supermicrosurgery?
Yeah, this is the maybe a training. Training is very important. I also always use a microscope and also find instrument and always every day we should use supermicro needle. So like chopstick for every meat. Yeah, eating Japanese Oriental people always use chopstick. I think this habitat is very important. Also, now MMI, Pisa, Italy completed micro robot. So now the European CE was allowed to use this micro robot. So I tried to use this micro robot several years ago. So this is amazing. So probably several years later, even all the professor can easily do the nanomicrosurgery with this micro robot. Also, probably standard surgeon can do supermicro and nanomicro with use this robot, micro robot. So now we are another new era. So this technique would be easily done by the young generation. Also, all surgeons, don't worry. New machine makes everything possible.
Well, that's very encouraging.
Yeah.
But before we could be in touch with that micro robotic, Professor Asman Sulaiman asked about how to get the tips from your side to prevent desiccations of the perforator vessels. In his experience, it seems that the desiccations come faster than in the normal situations with the microsurgical work without relying on perforator vessels. In my understanding, maybe you are fast enough so that you you have never experienced any desiccations of the pedicles, the perforator vessels. Do you have any tips whether you ask assistants to continuously drip the perforators with heparinized saline solution or other solutions or just saline solution while you are still doing other part of the work? Prof. Koshima?
Yeah, you're asking how to dissect the very tiny perforator?
Yeah, to prevent the desiccation, to prevent dryness, so that because the perforator, according to his observation, are fragile, easy to dry.
Yeah. You always, the assistant always make a moist. Dryness is very, difficult point. But the important technique by myself is I always coagulate a small branch of the perforator with electric scissor, standard big electric scissor. Standard electric scissor dissect the perforator with a standard electric scissor and coagulate small branch with this scissor, but they never coagulate the branch near the main trunk, far area. So never damage the main trunk. So this technique is very important and also very fast. Never use the bipolar. No need to use bipolar. Bipolar, it takes a time. So only one big standard electric scissor and cut, coagulate, transect. So no need, so bloodless dissection is possible. So when we started the live surgery 20 years ago, international microsurgical course, no other faculty member used this technique. Only me are using this technique. So other faculty member always criticize me. Oh, Dr. Koshima, you are very dangerous. But I say, oh, don't worry. This is most fast and also bloodless surgery. So nowadays, everybody, all faculty members do same thing as me. Everybody use the electric standard electric coating and dissect the perforator and coagulate the small branches. So this technique is very important. So in that sense, live surgical course of perforator flap had a very important role to popularize this technique all over the world. So please join and see the such a technique in the international course on perforator. But it's very expensive. So from now, no need to see. Yeah, next time I will show this technique movies.
Oh, good.
Yeah, this is important.
Everyone look forward to it. All right, so when you were saying that you avoid the use of bipolar, to coagulate the branches of that perforators, are you saying that you use microclip, or what do you mean with using
No,
scissors?
no. I always use the electrical cautery.
Oh, the monopolar.
Yeah, monopolar.
I
So
see.
monopolar, not only the coagulation, but the dissection of the perforator. So this is best. So if you start to use, so you never the use other instruments.
Okay, great. All right, so Prof. Koshima, in the work of Cipto transfer and the variations, including also nail flap transfer, you use digital draw. And I could see from your slide that you apply rubber tourniquet or something kind like, whatever material to apply or to serve as tourniquet. So do you also perform the LVA, like several LVA in lower extremity, by applying tourniquet, or
No, never use.
never?
Yeah, the LVA need not to use a tourniquet because I'm always doing the LVA under local anesthesia. So tourniquet impossible. And no need to use the tourniquet. Only inject the xylocaine E. So temporary hemostasis occur, maybe 10 minutes or 15 minutes. So within the 10 minutes, dissection is possible. And but the lymphatic channel show the contraction. So also training is also very important. So normal lymphatic channel
So
has.
do you think that you use that epinephrine with lidocaine also applicable to, let's say, for Cipto transfer or nail flap transfer without applying tourniquet, in your opinion?
Yeah, of course. Also, elevation for nail flap needs a tourniquet or the conventional. I use a Nelaton to block the root of the finger.
Okay.
Nelaton is very nice.
Yeah.
Also, in the replantation side, I always use a Nelaton with a Gita block.
I see. So the Nelaton catheter directly obstruct the fingers or the digit without any padding underneath. Just directly use the Nelaton tube, catheter.
Yeah.
All right, great. So, ladies and gentlemen, if you have questions, please welcome to use the raise hand button, or you could type in the chat box. I may continue with my questions, Professor Koshima, in regards of the arterial graft for distal replantations. I could sense that your arterial graft was actually used to bridge the gap of the venous flow.
Yeah.
That's very interesting.
Yeah. Because there are several arterioles, 2 or 3 arterioles from the digital arch. So one of the arterioles could be used as arterial graft for the venous connections. So size is completely same, and also the very easy to anastomose rather than a small venule. So this is one of the best choice.
Got it. Yeah, thank you.
Yeah,
welcome. All right, so very interesting, and I believe, the mindset of young generation need not to be frightened by the very small work because it's really possible, even in the hand of senior Professor Koshima, it's good. So meaning that both of us encourage everyone not to be afraid to start the work in the Supermicrosurgery, and then you could jump later on with the Nanomicrosurgery. You know, when he mentioned about cellular transfer, wow, big question on my head.
Yeah.
Several
It's a
times.
dream. Yeah. Probably several years later, someone succeeded cellular transfer or cellular surgery.
Right.
Nanomicrosurgery.
Yeah, I think it's not impossible because in the past we have never realized that lymphedema could be that great, fantastic outcome with that with work in the lymphatic vessels. I believe in the future there are many chances open for us microsurgeons to do more with the cellular transfer, even to heal or to treat patients with metabolic disease or diseases that I could imagine in the future. So let's follow the steps of Professor Koshima. Thank you very much, Professor Koshima.
Welcome.
Now allow me to bring the audience for game sessions before we end the session for today.
Yeah.
All right, so let's see. I have my assistants to start with the game. Now you could see in the chat box the link for joining the game. Yes, kahoot.it, and you would get the more questions, stimulating questions to give you a better understanding with the concept that he has just shared with us. This is very advanced, but if you realize it started many years back, oh, amazing. All right, so ladies and gentlemen, I invite you to join the Kahoot, and also would like to ask my assistant, Dr. Karina, would you please share your screen with the Kahoot while waiting for the participants to...
Hello everyone. You can click on the link on the chat box and enter the game pin as shown on the screen, 104568.
Give you one more minute. Only seconds. Okay. All right. I think it's just okay to start with the game. Let's start. So this is regarded as let's see. Good. Most of you are correct. Good. So let's see who is on top. The fastest among the participants who are correct with the answer. Okay, now we see R2D2 is taking possession. All right, let's move to the next. The lymph bypass would be considered a nanomicrosurgery work. Wonderful, great. Most of you are correct. Okay, now let's see. Oh, Jay is taking over. Congratulations, Jay. Let's move to the third questions. Example of nanomicrosurgery. Wonderful. I'm so happy to see that most of you, those who are correct are greater than the group who are wrong. That's good. All right, let's see whether Jay is still keeping his positions. Yeah, Jay, congratulations, Jay. Let's see whether you're able to keep your positions to the end. Going next, please. To reconstruct finger pulp using supermicrosurgical technique, one could use donor from challenging, I understand. So the corridor of the question was bringing you into the field of supermicrosurgery. So with that supermicrosurgery, you consider the medial plantar true perforator flap is the correct answer. Now let's see who's on top now. Whoa, Jay, wonderful, Jay. Let's see, going to the last one, whether you keep successfully your position. What is the pedicle of digital artery? Oh, if you listen carefully to what he explained, you would get the massive. This is basically by capillary perforators of the digital artery to nourish that digital artery perforator flap. Well done for the 7 people who are correct. Now let's see who's the champion of this game session. The third answer. He comes to the runner-up and was taken over by Great. Congratulations, Sab. Okay. Let's stop the game. Wonderful. I thank you very much to all the participants who took part with the game sessions, and I believe those who did not join the game also get the lessons, get the message from the game. Professor Koshima,
Yeah.
Our afternoon has been great because of you. You are our champion.
Yeah, thank you very much. Thank you. So I want to encourage the attendee for this meeting. So from now, I want to propose all about the new concept and technique So please enjoy with us, with me.
Yeah, great. We look forward to see you again with your more fantastic presentation and also videos if you are generous to prepare it for the participants. Wonderful. Thank you, Prof. And have a nice evening. To everyone, you take care and stay safe. See you again in the future.
Yeah.
Goodbye, everyone.
Thank you very much.
Bye.